In HER2-positive breast cancer, the current standard of care is a taxane plus trastuzumab plus pertuzumab. Then it's followed by maintenance strategy with trastuzumab plus pertuzumab. And those two antibodies together can be given for a prolonged period of time without any real side effects. You still monitor for a decrease in left ventricular function, but for the majority of patients, they tolerate this very well. And so now that we have DESTINY-Breast09 reporting out with trastuzumab deruxtecan set to move into the first line setting, I think the primary question there is going to be toxicities. Trastuzumab deruxtecan is an excellent therapy. It's very effective, but it does have some very serious toxicities. One of those is the pneumonitis rate of 10 to 15%, and that can be life-threatening. It certainly needs to be something that physicians should be looking for. And right now, there's some debate about how often do we screen patients for asymptomatic pneumonitis. I certainly have patients who I trust to be able to bring a dry cough or other side effects, symptoms to my attention, but sometimes you certainly have patients who we need to monitor very, very closely for whatever reason. Maybe they have COPD, and it's not as easy to figure out whether or not they're having pneumonitis. And so those might be patients you screen much more frequently. I think one of the criticisms of DESTINY-Breast09 is going to be, if we have a therapy that's very effective but is actually more toxic, should we be doing a strategy where we use trastuzumab deruxtecan for a certain period of time, maybe put people in complete remission, and then put them on a maintenance strategy that's more of a de-escalation strategy? So I think that's where the next types of clinical trials are going to go. That's a great question. So Hope Rugo yesterday presented some data on if someone develops ILD while they're on trastuzumab deruxtecan and it's asymptomatic, then you could potentially hold the drug and wait until it resolves and then re-challenge. And so some of that data needs to come out, and I'll have to look into that in much more detail. So it is possible to re-challenge some patients, but there was a rate of patients who are re-challenging developing pneumonitis anew. So I think those strategies are going to become more, hopefully, algorithmic, so at least we can try and figure out and help our colleagues who aren't seeing breast cancer all day, every day, how to deal with these toxicities that can become a problem in a general hematology oncology population. Absolutely. So with trastuzumab deruxtecan, one of the primary side effects besides ILD is also that patients can get pretty severe constipation and nausea. And because ADCs in general are much longer lived therapies, they hang out in the bloodstream and in the body for, in HER2's case, for 7 to 10 days. And so a patient who's severely fatigued and having a lot of GI toxicities, those side effects are going to last for a much longer than if you give someone a taxane, for example. A taxane, you could give them cold caps, for example, and preserve their hair loss or prevent their hair loss. And then there's more of a quicker recovery period, and they have more time where they feel a lot better than for some of the ADCs where they have a more of a prolonged period. In regards to dose reductions, these therapies do work at lower doses. The way that clinical trials for patients are designed is we hit a maximum tolerated dose, we go one dose notch below that, and then we carry that forward into our phase 2 and phase 3 trials. But the drugs do work at lower doses. We just can't always figure out in advance how low can we go, and that's probably different for different patients anyway. So we start high, we go down, and I think that for a lot of patients, they're worried that it might not be as effective as at a lower dose, but we know in real world data that that's not the case. For dose reductions, I do tend to tell my patients up front that we start high and we go down. It's the opposite of if I'm putting you on a blood pressure medication and I'm starting low and going up, I'm titrating to that. In oncology drugs, we titrate to the toxicities. So that's quite a different way to do medicine, but it's just the way that oncology medications are dosed.